Welcome to the Health Professionals Co-Design of St Vincent's Health Safe Haven Feedback Loop #1. My name's James. I'm from Rose in the Ocean, one of the facilitators, to be fortunate to be a part of this fantastic program and project, and really have appreciated to date a number of things that have been raised and the conversations that we've had with both the health professionals and the lived experience. So before we start, as we always would, I'd like to do an acknowledgement of country, and particularly the traditional owners on the lands on which we, in fact, the St Vincent's Hospital Sydney resides, and those being the Gadigal people of the Eora Nation, and pay our respects to their elders past, present and emerging. Also like to, if we could please, do an acknowledgement of lived experience and acknowledge those who have maybe considered ending their lives and those who have attempted to do so. Of course, acknowledge those who are caring for loved ones who are currently in suicidal crisis. Also those, and acknowledge, that have been bereaved through suicide, and as well acknowledge those that we may have lost to suicide or who may be struggling with life today. Everyone's lived experience is unique and everyone's lived experience is valuable. And of course, everyone's lived experience can make a difference. I want to show you a number of slides, and I'll share this here if I can. Just to walk you through essentially where we're up to today. We've, had a webinar similar to this with the lived experience participants just earlier today. And it's the process so far, as you can see there on the left-hand side, orientation webinar, information pack, New South Wales Ministry of Health guidelines document, conversations with the lived experience groups of 3, and of course, the health professionals. And thank you for those that have been involved. Thank you for those that can join us on this webinar, and/or thank you for those that can join us later on and watch the webinar. But the health professional focused conversations as well. We've had lived experience sessions, a couple of those, in fact, at 2 hours each. And today is about essentially feedback loop 1. So providing a little bit of context about the co-design process. Certainly trying to ensure that we've captured or picked up as much as what's been shared during the first round of the co-design, and to gather a little bit more broader views and experiences across the various experienced people. Explore what is missing as well, tap into a little bit of that, and, pardon me, and help prepare for round 2 of the co-design process. So what we did is, we having conversations with the health professionals around feelings, needs and ideas. In particular, the role of being a health professional, supporting someone through the process of finding and accessing support through the emergency department, or ED, and exploring their feelings and the reasons why they felt that way and what needs they had at each stage, or what we call the kind of phases or touch points, as you can see there. And those being the finding, the actual finding of the ED, the arriving, the checking in, of the ED, that waiting time frame, the treatment or management time frame or touch point, and the departure or leaving of the ED. So these touch points we've picked up around feelings, needs and ideas. So the next few slides are going to highlight some of the key points of that discussion, feedback from this first phase of the co-design. As I mentioned, everything that was shared in the conversations has been captured with the most common shown themes. Let's have just a brief kind of overview of who we met with in terms of the health professional conversations. Those so far that we've captured were a peer worker, nurses into mental health, emergency department psychiatry and a clinical consultant, an emergency department specialist staff, alcohol and other drugs counsellor, a community organisation manager, and St Vincent's Hospital unit managers. So a number of conversations been had, which has been fantastic in terms of the insight and knowledge that's been provided so far. So as mentioned, it was about trying to understand your experience as health professionals and what it's like to work in your shoes supporting somebody in suicidal crisis. Let's have a look at that first touch point, the finding, and what we found from these conversations. You'll see the little wordles on the left-hand side. These are some of the things that came up in terms of describing what the feel was, and those being urgency, frightened, and empathy. The finding why they felt this way. So health professionals reported needing to be calm to provide support in a safe way, feeling a sense of urgency when on the phone with someone experiencing a suicidal crisis, as they could hang up at any time. Feeling a responsibility to act for, pardon me, for people in crisis. Not wanting to put pressure on the emergency department and avoiding taking patients there. Performing risk assessments and other assessments to determine patients' needs and options, and only calling an ambulance when it's beyond their scope. And finally, one of the findings there within this finding section was that the importance of connection in supporting people experiencing suicidal crisis. So the finding, some of the comments or direct comments that came out of health professionals were you don't have to understand, but connection is really important. There's a sense of urgency as people can hang up on us at any time, and therefore there is very limited opportunity for somebody seeking emergency help. I needed to be calm and provide support in a safe way. It feels pretty frightening around their welfare and there being a limit on what you can do without people disclosing more information about their whereabouts and location. Let's have a look at that next touch phase that we explored, and that being the arrival and initial assessment. Health professionals' feelings were empathy, overwhelmed, driven to help, feelings of bad, distress, anxiousness, or guilt. And the conversation, the insight that's been provided as to why these feelings came across were a feeling driven to help and understand people's experiences. The importance of making people feel safe and comfortable in the emergency department. The busyness of the emergency department space, sometimes getting in the way of communication. The whole system not giving them enough time to support people in suicidal crisis, which results in feelings of guilt. Acknowledging complaints in an appropriate way is challenging in ED, and the importance of acknowledging people's experiences, providing reassurance and engaging with a sense of comfort. The importance of communicating wait times was certainly another thing that was popped up. So that arrival and initial assessment, direct quotes that we had were, the emotional weight on the patient side is so large coming into a busy ED. Sometimes I feel like my colleagues don't take it seriously enough or have made a judgment on the person presenting. We're not providing a safe environment for people to share their stories, and I want to make the people feel warm from an emotional point of view. So moving into that waiting touch point or phase, health professionals felt uneasy, angry, fear, a sense of sadness, bad, frustrated, disappointed, stressed and worry. And health professionals reported these feelings because of using this time to try and understand what is going on for people, their life supports and what worked for them in the past. Feeling uneasy at that some colleagues don't take suicidal crisis presentations seriously or make judgments about people presenting. Patients leaving the ED without treatment due to wait times. Pressure on the ED causing wait times to become extended. Feeling a sense of responsibility to manage client expectations and communicate with them regarding wait times. This part of the process being the worst. Hesitancy to enact the Mental Health Act if not required. Instead, wanting to build a level of trust and a solid relationship. Some direct quotes that came through in this waiting period. People are having a personal crisis and are left in a corner and not listened to when they have shared these big things going on. Not being able to see people quick enough means they leave and we have missed a chance to help. My role is to reassure people that waiting is part of the process. I see people waiting for triage, assessment, and feel very uneasy because people have a fear of talking to them. The treatment phase, health professional feelings that came out was wanting more, sense of suspiciousness, relief, drained, stress, anxious, guilt, frustration, distress, annoyed, helpless, pressure, angry, and responsibility. And the health professionals reported a feeling that emotional price of working with patients experiencing suicidal crisis, feeling a responsibility to educate those they are working with, and building rapport has been the biggest challenge of the initial treatment. Feeling anxious about people's safety, feeling stressed about missing things from a risk perspective. The focus always been on what goes wrong, but some occasions resulting in wonderful outcomes where they've made a difference in someone's life. It's good to see some positive feedback there as well. And feeling that what they can offer being a small benefit compared to the magnitude of what people may be or are facing. Some direct quotes in that treatment phase. I want to do nothing after working with them. Sometimes you need to hold in this emotion as you are in an encouraging capacity. Sometimes those present frequently don't get the same experience. Often though, these patients will be avoided in fear of doing the wrong thing, and a sense of helplessness around what we can meaningfully offer. Fear and frustration as the availability of services in emergency department for suicidal crisis is poor. This is difficult. The final stage was the leaving, and health professionals feel stunted and positive, helpless, hope, anxious, fear, worry, nervous, glad, happy, guilt, reassured, desperate, frustration, struggle, and disappointed. And they're reported of feeling an expectation to solve things for people. It can be challenging to set boundaries with people seeking help and realise you can't be with people 24/7. Mixed feelings depending on people's state of mind when they leave. People leaving due to the perception they're not going to get the help they want or need. Feeling there's a problem with the system and lack of awareness of the process in the system. And awareness of the limitations and inappropriateness of ED in supporting people experiencing suicidal crisis. And finally, in the leaving period, the feeling or reported from the health professionals is the follow-up service has been lacking, expensive and or difficult to access. Some direct quotes from that leaving phase. If we are able to link into decent support and recovery outside the hospital setting, this can be a great outcome. If they are going back to the same situation, I feel very sad and frustrated for them. They are getting back into unhappy habits. Sometimes I worry about people leaving without treatment because follow-up services are lacking, expensive or difficult to get to, and a feeling of frustration around people being given a pamphlet and sent home. So then we open up conversations around what is needed, what could we do with this co-design, and what, in particular, what's missing from the services available from our region. And some of the comments that came through, pardon me, services tailored to servicing the First Nations community who access services and deal with crises in a different way. Pre- and postnatal services, LGBTIQ+ services, aged care services, psychologists and rehab accessible in a timely manner, a space for hope and recovery, a service which gets to know people well in order to understand why their mental health is declining, a service which helps empower independence and gets people back on track, work, purpose and vocational support, peer-led groups and a space to talk to someone to understand their experiences. And then we discussed what do you need to feel comfortable with supporting people to access a safe haven? And the lived experience in mental health professionals who can support diverse communities, as we see there, the LGBTQI+, First Nations, etc. Be able to refer someone and have them receive support. Peer workers, so people feel heard. Onward referral opportunities, so people can be pointed in the right directions. To know the consumer or guest journey when they arrive, who is there, staff, groups, and a timetable as such. A sense of consistency of opening hours. To know what support and professional visitor ratio might be or is. And enough support around with peer support amongst the visitors and guests. The right people are involved, making sure they're passionate and want to be there. Some great feedback there. So lots of we've covered there in terms of ideas and feelings and why health professionals felt that way. So I want to thank everybody to date that's been a part of that process. And the next slide after this will give access to the survey as well. So for those that haven't had a chance to be a part of it, please send that survey around, and or if you think there might be something missing or you can think something you'd like to add to that conversation and ideas and feelings, please feel free to fill that survey out. The next steps, the health professional session provided with the lived experience outputs. That's around the 8th of June. The feedback loop 2, another live webinar with the survey questions and the review of documents around the 15th of June, I think it is. The joint stakeholder session, session 3, the feedback loop number 3, and the live webinar to communicate the co-design outputs to the local community around the 29th of June. So this is, as this next slide describes, over to you, an opportunity to provide some feedback from within the survey around this to how far we're up to date. Please log into that link there and check out the survey, an opportunity for you to provide ideas and answer some questions to the survey. Thank you for your time. Unless there are any questions, I can see there's a couple of participants online. Unless there are any questions, I want to thank you all again for the process and support, insight, knowledge and wisdom you've provided to date. Thanks again, and look forward to seeing you over the next couple of sessions. Thank you.